Hey all, welcome back to the Real Life Pharmacology podcast. I'm your host, pharmacist Eric Christensen. Thank you so much for listening today. As always, go get your free 31-page PDF on the top 200 drugs. It's a great study guide, great refresher if you're out in clinical practice. So simply go into reallifepharmacology.com. An email will get you access to that. We also get you email updates when we've got new podcasts and other content available as well. So go do that. Sign up for that free 31-page PDF at reallifepharmacology.com. Let's get into the drug of the day today, and that is Aliskiren. Brand name of this medication is Tecturna. And this medication is classified as an antihypertensive, so it's going to lower blood pressure. And it's also classified as a renin inhibitor. So if you think about the renin-angiotensin-aldosterone system, you'll recognize that Aliskiren, being a renin inhibitor, is also going to work on that pathway. So mechanistically, by this drug essentially reducing the activity of renin, that's going to ultimately block the conversion of angiotensinogen to angiotensin 1, and then so on and so forth. So because of that blocking, that's going to ultimately lead to a reduction in blood pressure due to vasodilation. Remember, angiotensin 2 is the most potent vasoconstrictor, and that's further down that line in that cascade of the formation of different metabolites and alterations to angiotensinogen and angiotensin 1. So, again, reducing that renin activity ultimately blocks that conversion of angiotensinogen to angiotensin 1, which is in that pathway of increasing angiotensin 2. So, going to lead to vasodilation and obviously lowering of blood pressure. This medication is typically dosed once a day, so that is definitely an advantage. And this medication is typically more expensive than your traditional ACE inhibitors and ARBs and things of that nature, which lends to an important education point. This drug should not be used with an ACE inhibitor or an ARB. I've seen that out in practice a couple of times, I think, if I recall correctly. And I think it's on account due to people not recognizing what Aliskiren is and just not recognizing that that drug works on that system as well. So we wouldn't want to use that with an ACE or an ARB. The dosage forms, it's 150 milligrams and 300 milligrams. And again, dosing is once daily on that, so pretty straightforward there. All right, let's talk adverse drug reactions a little bit. Really fairly well tolerated in general. Obviously, it can lower blood pressure, so hypotension and dizziness can happen. Diarrhea, rash, kind of, I guess, more common adverse effects, but again, you generally don't encounter them very often. Some rarer things, cough isn't incredibly common, definitely less so compared to ACE inhibitors, for example. It can potentially contribute to a rise in creatinine, which is going to increase the potential for acute renal failure. Can increase or has been associated with increases in CPK as well. Again, all these are very rare, but if you remember CPK, where we talked about that, that's definitely a statin thing as well there. So again, not something I'm incredibly worried about with this medication, but something to pay attention to if you notice something clinically off there. And then in pregnancy, this medication is absolutely recommended to avoid because it can lead to fetal harm and fetal risks with this medication. Administration and potentially some interactions there that may alter absorption and things of that nature. So when you give this medication with a high-fat meal, it can reduce absorption of the drug. So if you notice a patient not responding or something to that effect, it might not be a bad idea to inquire about how they're taking it, because taking it with a high-fat meal can lower the absorption. Now, the recommended way to take this medication is basically to be consistent, which generally makes sense to me. So, really no preference as far as food or no food, but consistency is probably the important education point there. And then obviously we can monitor patients clinically. We're going to look at blood pressure and things of that nature. So in addition to monitoring blood pressure, obviously working on that pathway, working similar to ACEs and ARBs, you can anticipate that elevations in potassium can happen, and I apologize for omitting that in the adverse drug reactions, but obviously that is an important adverse drug reaction that we need to pay attention to and monitor. So one of the most important adverse drug reactions. And renal function is going to be important as well. So you're going to monitor creatinine, blood urea nitrogens, or BUN, it's often referred to as, and ensure that those aren't going up in a significant fashion. Pharmacokinetics, pharmacodynamics, half-life is 24 hours, so it makes sense that we can give this medication once daily. 25% or approximately 25% is excreted in the urine. So as you can imagine, if we've got patients with poor renal function, that could impact concentrations and make those concentrations go higher and increase the risk for adverse drug reactions like acute renal failure and increase in potassium and things of that nature. All right, let's take a quick break from our sponsor and we'll wrap up with drug interactions. If you're in the market for any pharmacist board certification study material like BCPS, ambulatory care, geriatrics, BCMTMS, or others, go check out meded101.com/store. We've got a growing list of resources there, helped thousands of pharmacists prepare and pass their board exams. So go support the sponsor, meded101.com. That helps keep this podcast educational and free for all to benefit from. If you're not a pharmacist and not taking a board exam anytime soon, definitely go check out meded101.com/store. We've got a list of books that can be really relevant towards clinical practice on polypharmacy, drug interactions, food medication interactions, case studies, tons of different resources there that can be really helpful for you. So all those links at meded101.com/store. All right, wrapping up with drug interactions. So I alluded to this already. What you want to think about is potassium with Aliskiren. So elevations in potassium can certainly happen and patients can be at greater risk when they're on other medications like ACEs and ARBs that can increase that risk for hyperkalemia. So absolutely recommended to avoid ACE or ARB in combination with Aliskiren. In addition, spironolactone can raise potassium levels. Trimethoprim is another great example that can increase potassium levels. So really be on the lookout for that, and at a minimum, make sure we're carefully monitoring for that. NSAIDs, diuretics in combination with Aliskiren can increase the risk for acute renal failure. So that's something important to monitor for and try to minimize the OTC use of NSAIDs if possible, or at least limit that duration. As well as paying attention to any prescribed loop diuretics or thiazide diuretics. They can increase that risk for renal dysfunction. And then, of course, we've got blood pressure changes. So some medications can certainly oppose the beneficial blood pressure lowering effects of Aliskiren. Stimulants are a great example. NSAIDs can sometimes contribute to that. EPO-type agents, erythropoietin-type agents can raise blood pressure and directly to oppose the effects of Aliskiren. Lower blood pressure, so drugs that can basically have additive effects onto Aliskiren that aren't considered kind of classic blood pressure medications or blood pressure lowering medications. PDE5 inhibitors like sildenafil. Cinemet's a good example, used in Parkinson's disease. Some antipsychotics more than others can cause some orthostasis and lower blood pressure. Alpha-blocking agents used for BPH, like tamsulosin. These are all meds that can have additive blood pressure-lowering effects and may cause that blood pressure to go a little too low. Cyclosporin, immunosuppressive type agent, not used incredibly common, but this can increase concentrations of aliskiren, so you might want to pay attention to that. And grapefruit juice, so kind of a food dietary interaction, does have the potential, or has been reported, to lower concentrations of aliskiren. All right, well, I think that's going to wrap up the podcast for today. If you enjoyed this episode, you can definitely go leave a rating and review on iTunes or wherever you're listening. Also, please support the sponsor, meded101.com/store. Your purchases there go directly to support this podcast and keeping it going, so I greatly appreciate that. Any comments, suggestions, feel free to reach out to me on LinkedIn, Eric Christensen, PharmD, BCPS, BCGP. Or you can email me, mededucation101@gmail.com. And with that, I'm going to sign off for today, and I hope you have a great rest of your day.